Hi everyone, I am Dr. Sagar Sahu and welcome to Vet Surgery at Each. So today we will be starting a new series on, of course, your demand, that is the ultrasonography. First we will discuss the basics of ultrasonography. I have discussed regarding the lectures in my Instagram channel. If you are not following there, please do follow there. Okay, so from today we will be starting the ultrasonography and I have a very special request. Okay, please give feedback regarding the lectures because this is the only field which I have a little less experience rather than other fields like orthopedics, anesthesiology and general surgery. Okay, I am very much comfortable in those topics because I have good, not good, fair amount of experience actually. I am still young, but in this field I have little less experience. So what I will be covering, those will be more theoretical oriented rather than the practical orientation, but you need some theoretical background before going into the practical, so this will be very helpful for you. So I need some feedback. If some points are missing or something you feel missing, do comment down below, and if it is good then also comment down below. Okay, so today we will be starting the first one. Here we will be discussing about the basic principles of ultrasonography, what are the instruments used, mostly the transducers, and what are the modes that are commonly available with the ultrasonography. Before going to the video, some formalities, you know this. In the Facebook I post different cases pictorially. Important one is the Instagram, where I give updates regarding the videos as well as the notes are posted in the Instagram. And this is my channel, please do subscribe. This is a book which I am currently referring for preparing the lectures. Okay, for all the series, this book will be the reference. I will give the link of this book, this PPT, and also the notes in the description. Okay, you don't need to worry about those things, simply listen what I am telling. So this is the small animal diagnostic ultrasound, elsewhere publication, very good book, more theoretical book, but I will keep it like very simple. Okay, if you want detail, then go to this book. The first, some basic principles regarding the ultrasonography. See, these classes will be mostly from a doctor point of view rather than the technician point of view. Okay, there is sonographer and there is sonologist. Okay, sonographer is mostly technician, sonologist is a doctor. So it will be from sonologist point of view. If you want more physics, more technical things, you can refer the book. Okay, we will be covering mostly from a doctor point of view. Okay, sometimes you don't need to know all the physics things, you simply have to know that what are the things is there. Okay, so the diagnostic ultrasound, mostly we will be dealing with the diagnostic ultrasound. There is some theory regarding the ultrasound, sound waves, all those things. I am skipping all those things because those are not necessary for a doctor. Whatever necessary I will be covering. So what is diagnostic ultrasound? It is basically high frequency sound wave, 2 to 15 megahertz sound wave that are pulsed. Remember the term is pulse. Okay, it goes on the principle, or it is based on the principle of pulse and echo. Okay, it is not a continuous wave that is sent to the organs for the ultrasonography purpose. It is a pulse. Okay, pulse. I will discuss regarding what are pulse. Pulsed into the body, and the returning echoes, pulse and echo. Returning echoes are then analyzed by the computer. Okay, then a cross-sectional image, you will see yield high resolution cross-sectional image, mostly 2D. Nowadays there is 3D, 4D also, but mostly it is 2D cross-sectional images of organ or tissue or blood flow. Blood flow, which you know that Doppler is there for blood flow. Unlike with other imaging, these two are actually the precautions, or you can say some cautions. Unlike with other imaging modalities, interpretation is best made at the time of study because the probe position is different, can vary, and if you slightly change the probe position, the images will be varying. Okay, for that it is best you should interpret at the time of study, and it is very difficult to render a meaningful interpretation from another sonographer's static image or video clips. I told you, because if slight change in probe position, the image will change. Okay, the organs will change, all those cross-sectional things will change. Okay, that is why it is better to interpret at the time of study rather than sending some video or images to other sonographer. Sometimes it is, you see, there are some things which are very conclusive. Okay, if you send someone, you can tell some things. Suppose there is a bladder and there is some stone, there is acoustic shadowing, you have sent it someone to diagnose, then he or she can tell you that this is a case of urolithiasis. Okay, urolith. But In general, it should not be like that. You should not be interpreting from someone other's image or video. Okay. Next is the some basic data, or you can say basic assumptions, which are taken for ultrasonography studies. Sound wave, you know that it is a pressure wave. It has compression and rarefaction. Okay, compression, this tone is compression, this is rarefaction. And you know that wavelength is the distance between two successive compression or two successive rarefaction. Frequency, okay, in 1 second how many compressions are there in 1 second, compression or rare, how many waves are there in 1 second. Frequency, they are inversely proportional. If wavelength is more, then frequency will be less, or here we will be mostly using the term frequency. So higher frequency has a lower wavelength or shorter wavelength. Range of human hearing is 20 to 20,000 hertz, but diagnostic ultrasound has 2 to 15. Okay, 2 to 15 actually. Diagnostic ultrasound 2 to 15 megahertz. This is the range of a diagnostic ultrasound, so it is not audible to human ear. Average velocity of diagnostic ultrasound is 1540 meter per second. It is taken as assumption, but it varies from tissue to tissue. Like here you can see, important one is the air and bone. You might have heard during some ultrasound imaging that sound cannot pass through the air or bone. Why it does not pass, we'll discuss in subsequent time. Okay, but just see the velocity. All other things, it is nearly like 1540. Okay, 1620, 1525, 1570, 1561, 1549. Okay, all those around 1500. Okay, but look at the air, 331. Look at the bone, 4080. Almost 4 times more, it is almost 4 times less. Okay, that is why there will be some problem with sound wave traveling in the air in bone with regards to the ultrasonography. Okay, we'll discuss, okay, when we'll discuss the acoustic impedance. Next is how the images are actually formed. 1 minute. Okay, how the images are formed. I told you that it is not a continuous wave that is sent into the body. Why? Because if you are sending a continuous wave to the body, then the echoes while coming back will interact with the waves continuously sending. You are sending, the machine is sending. So when there will be interaction between the sending waves or going waves or moving towards the body waves and from the echoes, what will happen? There will be interference. The images will not be formed. So what actually it does, the machine does, it will send one pulse, it will go back to the bottom, to wherever it can go. Then some reflections will be there from different interfaces. Interfaces means, suppose there is a muscle, then there is fat, then muscle fat interfaces, it will send some signal. Then the fat or some, you see some air comes, then there will be interface, it will send some signal. Okay, so on the basis of those signals, okay, it will hear. First it will send pulse, the echoes will come back, machine will receive it, analyze it, and depending on the time taken from the pulse to echo, it will determine that what is the distance of those structures from the transducer, and it will map. Okay, so here you see there are two interfaces. This is interface 1, this is interface 2. Now one pulse is going, single pulse is going, and it has hit the interface 1 and there is one echo. This is echo 1. Next it will hit the interface 2, there will be second echo. So these echoes will be analyzed by this transducer or the machine, then it will form some images. Like see here, this is a single scan line. Okay, you can tell that this is a single pulse line, but the appropriate term is scan line. So this single scan line, you can see multiple dots. Can you see multiple dots? These are multiple dots depending upon the echo, strength of echo. Strength basically represented by amplitude, the height of the wave. So these, based on the amplitude, it will fill out the dots. You can see clearly those dots. Some are white, some are gray, some are dark. Okay, depending on the intensity, it will put some mark as shades of gray. You see, machine can produce really nearly 120 to 500 different shades of gray, but human eye can interpret about 10 to 12. Okay, around this much human eye can interfere, or you can say recognize these 10 to 12 shades of gray, but machine can produce 120 to 500 shades of gray. Okay, so based on that these dots are formed in the shades of gray. Here I will discuss, there are two views. This is near field, near field, near field. You can see here will be the transducer, this here will be the transducer. This is near field, this is far field, this is far field. If you look closely, the near field dots are more bright. You can see it is more bright, while the far field is comparatively darker. Why? So when the sound wave or the sound pulse will traveling towards the far field, it will continuously lose some amount of energy. It will be hitting different, you see here there is a gap between those interfaces, but in body it will be very close. So all those gaps it will be hitting, all those interfaces it will be hitting. When it will be hitting different interfaces, it will be sending some reflections. So while sending those reflections, it will get weaker and weaker. So those strong pulses, here there will be strong pulses, it will be denoted as bright, more bright or white shades. While it will become weaker, it will have more darker shades. So usually, unless or until other settings are you can say manipulated, we will discuss what are the settings are there manipulated. Usually the far field will have a darker appearance, the near field will have a brighter appearance because of the strong reflections. These getting weaker, the process of getting weaker is known as attenuation. We will discuss attenuation separately. It has three types of attenuation. So one among them is reflection. Due to the reflection, the images will be formed, and there will be gradual attenuation, gradual weakening. That is why the shades you can see here more bright, here more dark. So this is a single scan line, you can see dots. Now what will happen, the machine will send pulses like this. It is known as beam sweep. One beam will go and it will sweep the entire field. You can see here multiple scan lines, these are multiple scan lines, it causes beam sweep. One entire beam sweep is known as one frame. This one frame. Similarly, what will happen, in one frame the image will be formed, okay, but if will not do continuously, the image will be lost. So it will do multiple sweeps, that is known as frame rate. Multiple sweeps, and in the monitor you will be seeing the image. Here you see this is the actual transducer which is malfunctioning, but here you can see multiple scan lines. You can see multiple scan lines. Okay, so when they will be, if it is functioning properly, you will not find those gaps. Okay, you cannot see those scan lines. Then one image will be formed. Continuous beam sweep, continuous image formation. Continuous beam sweep, continuous image formation. In this way, the ultrasonography image is formed. Okay, so now you understood the far field, the near field, how the beam gets attenuated, how the spots are formed. Okay, the depth of these spots or these interfaces will be calculated by the machine, because we are assuming some velocity, and the time taken to reach the spot and coming back, the machine will calculate. This simply physics. Okay, you don't need to know. If you want to study further, then you can refer the book. I will give the link in the description. But simply from a doctor point of view, you should know this. Okay, so when it will get weaker, it will become more darker. When it is stronger, or you can say intensity is high, it will have a brighter shade. Okay, so this is how the image is formed in ultrasonography. Next is the comparison between a lower frequency and higher frequency. Here this is higher, this is lower. Higher is 7.5 megahertz and lower is 3 megahertz. It does not necessarily mean is 3 is lower. Suppose you will be comparing with 3 and 1, 1 will become lower, 3 will become higher. If you are comparing 12 and 7.5, 7.1 go to lower and 12 megahertz will be in higher. So just a comparison. Regarding the wavelength, there are certain parameters regarding comparison. So regarding the wavelength, see, the frequency is inversely proportional to wavelength. So when it is higher frequency, the wavelength will be lower. Okay, lower frequency, the wavelength will be higher. Pulse length, you see, when there will be higher frequency, the pulse length will be shorter. Pulse length will be shorter. Pulse length will be shorter. Why? You see, usually when I will discuss regarding the pulsar, the instrumentation, the pulsar, when in single pulse, you will find 2 to 3 wavelength, 2 to 3 wavelengths. As the wavelength is lower in case of the high frequency probes, so the 2 to 3 wavelengths, the length will be shorter than this 3 megahertz transducer. Okay, 3 megahertz sound wave, you can say that. Okay, so the pulse length will be shorter in case of the higher frequency probe, and it will be longer in case of the lower frequency probes. Okay, next is axial resolution. We will discuss the resolution subsequently after that, but here for your understanding I am explaining what is the resolution, axial resolution. You see, axial resolution means resolution along the beam. Suppose this is transducer, suppose this is transducer and this is the field. Okay, so the beam will be coming like this. I discussed the beam comes like this. So if there will be 2 points situated in this particular direction of beam, then it is known as axial resolution. The ability to distinguish between these 2 points, okay, is known as axial resolution. Suppose it is shorter, what will happen? Here are 2 points. One pulse is coming which is kind of shorter. Suppose this is shorter. Okay, it comes like this, comes like this. When it will touch here, this particular length, this length, it will send a reflection. Then it will move and it will touch here, here. Then it will send a reflection. These 2 reflections will not be merged because this is smaller in length. Let me draw it. Here is one point, here is one point. The pulse length is shorter, and when it will hit here, it will send a reflection. Then when it will hit here, it will send reflection. Suppose this is near point, this is far point. So when it will hit the near point, it will send a reflection. Then it will move to far point, then it will send a reflection. These 2 reflections will not be merged because this length is very short, you know. It will hit here, then it will move across. Before hitting this one, this reflection is complete. When it will hit, then another reflection will come. So these 2 reflections, there will be gap. So in the image, it will be reflect as 2 separated dots. But if this having a lower frequency probe and the pulse length is bigger, what will happen? So here is one point, here is one, but this particular wavelength or the pulse length is bigger. What will happen? It will come like this. When it will hit, it will send a reflection and it will come like this, like this. When it will hit the far point, it will send a reflection, but the entire pulse is not yet crossed by the near point. Here it has not crossed entirely. So when this reflection will go back, it will be merged with this far point, or the near point reflection. Okay, understood? So this is the length of the pulse. It will come like this, like this, like this, like this, and here it will send a reflection. But here some point is there. This much length is there. Okay, the reflection of near point is not yet complete. Okay, so what will happen? This reflection will get merged with this reflection. That is, the far point reflection will get merged with the near point reflection, and it will look like as a single point. It will, in the image you will find a single point. So it is not distinguishing these 2 points when you are comparing the shorter pulse length with the longer pulse length. Okay, so when there will be very good distinguishing between the points, the resolution will be high, the degree of clarity will be high. Okay, that is why it is said that when you will be going for higher range probes, the resolution will be better than the lower frequency probes. This is known as axial resolution. There are different other also, lateral also, azimuth resolution, all those things are there. But more important is the axial resolution. Axial resolution is the better in case of the higher frequency probes, and it is comparatively lower in case of the lower frequency probes. Attenuation is much faster with higher. Why? Suppose this is the tissue thickness. Suppose this is the tissue thickness. This much is the tissue thickness. The higher frequency will travel like this. As it has higher number of waves, it will travel like this. While the lower frequency, how it will travel? It will travel like this. You see how much tissue interaction in the higher frequency and the tissue interaction in case of lower frequency. So when there will be more tissue reaction, sorry, tissue interaction, not reaction, tissue interaction of these frequency, higher frequency wavelengths, or you can say sound waves, it will get attenuated faster. Okay, attenuation I will discuss. There are different other things, right? Other than reflection there is also absorption, there is scatter. So all those things will be higher in case of the higher frequency probes. So attenuation is the faster, you can say faster or higher in case of high frequency probes. So and lower in case of the low frequency probes comparatively. Okay, here we have taken 7.3. if you will take 12 here, 7.5 will be the lower. When it is attenuated at a faster rate, so penetration will be less in higher frequency, penetration will be high, or you can say better in case of low frequency probes. So when you will be using a higher frequency probe, you can get a very good resolution, but the penetration is low. But when you will be using a lower frequency probe, you will get fair good resolution, but penetration is higher. So suppose you are doing abdominal scan of a species, okay, the dog breed species, there you can use a higher frequency probe because usually the length is less, so you can use higher frequency and get good resolution. But suppose you are doing in Great Dane, or you can say Saint Bernard, giant breeds, in that you cannot penetrate the entire abdomen, okay, with this particular higher frequency. You can scan up to very limited things. So in those cases you can use the lower, though there will be some compromise in resolution, but you will get good penetration and you can visualize the images, deeper images, usually the far field images, or far field organs. So this is basic difference between the lower frequency, the higher frequency and lower frequency, okay, those probes. Next, the acoustic impedance. This is one of the most important concept in ultrasonography. So what is acoustic impedance? Acoustic impedance is denoted as Z. It is basically the product of velocity and tissue density. In diagnostic ultrasound, velocity is comparatively assumed to be 1540 meter per second. So velocity is constant. So it is directly proportional to the tissue density. So here you can see some values regarding the acoustic impedance. Notice the air and the bone. Others are like 1.5 to 1.7 or 1.8. But look at the air, 0.0004, and look at the bone, 7.8. Okay, what is the application of acoustic impedance? So acoustic impedance determines how much sound wave will be reflected back. Okay, it determines the percentage of reflection at interfaces. Interfaces means two different type of tissues. So here you see blood brain interface, 0.3% reflection. It means 99.7% will pass to deeper structures to evaluate further things. Suppose there is liver and a muscle, 7.9%, nearly 8% will be reflected. 92% will pass and will be available for deeper structures. But look at the brain and the bone, 66.1% will be reflected, nearly 70%. 66, let us assume 66% will be reflected back. Only 34% is remaining. So those may not be sufficient for the evaluation of the deeper structures. That is why it is told that sound waves or ultrasound cannot pass through the bone, because most of them will be reflected back to the transducer and there isn't enough to scan below. Look at the soft tissue and the gas, 99% will be reflected back. Only 1% will be available to go further those interfaces. 1% is nothing. Okay, so when nothing will pass through the bone or gas, so sound wave will not be passing through that interface, so it will appear black. Okay, that is known as acoustic shadowing. There is another one is acoustic enhancement. This is also because of difference in acoustic impedances between those structures. but we will discuss artifact in the next class. Interpretation of the images as well as artifacts will be discussed next class. There I will discuss in detail what is acoustic shadowing and what is acoustic enhancement. It is because of different tissue density or indirectly acoustic impedances. Now you will see a radiograph. Here you see a radio, sorry, I am really sorry, I am still in radiograph. This is ultrasonography image. This is the image of a shoulder joint. Here this is scapula, this is scapula, this is the glenoid tubercle, and here this is the humerus, Over the bone mostly you will find muscles. This is muscle. So this is muscle and bone interface. Okay, so when there will be muscle and bone interface, I told you nearly 66%, or you can say, suppose in rough 70% will be reflected back, 70% will be reflected, all the sound waves coming will be reflected back to the transducer, nothing available here. So this is completely back, or you can say it is now shadowed because of this bone shadowed. This is acoustic shadowing. Okay, we'll discuss later detail. So for your understanding I am telling, this is shadowed now, completely black, because there isn't enough sound wave available for evaluating the structures below this bone. So this is basically the importance of acoustic impedance. Okay, next we'll know about the spatial resolution. I told you one axial resolution. So there are three kind of resolution: axial, lateral and azimuth. So the y-axis you can see here, this is axial resolution, and the x here, this is the lateral resolution, and the z, which is perpendicular to the x and y, is basically the azimuth or elevation. Also it is called as elevation, also as azimuth resolution or elevation resolution. But in 2D image, two resolutions are important, that is the axial and lateral. Okay, here you see along the beam is the axial, and this is the lateral. This is the lateral resolution. I have discussed regarding the axial one. Okay, regarding whether depending on the pulse length, how axial resolution changes. Shorter the pulse length, better is the axial resolution. Okay, longer the pulse length, there will be less resolution. So axial resolution is inversely proportional to the pulse length. When it is inversely proportional to pulse length, it is directly proportional to the frequency, because higher frequency has shorter pulse length. Regarding the lateral resolution, it is inversely proportional to the beam width. You see, beam width is not uniform. The beam which are coming, you can see here there is beam. Okay, beam width is not uniform. It is wide at some point and it is narrow at some point. When it is narrow, the narrowest point is known as focus. So at this point, as the beam is very narrow, you can identify better, there will be better resolution, because when there is narrow, it can point down two different structures. Like here, suppose there is two different points here. Okay, when the beam is narrow, it can differentiate this one, it can differentiate this one, but when the beam is wide, it cannot differentiate these two. Okay, because it is going right through it. When there is thinner slice, it can go through here, it can go through here, it can produce as two separate images. When it is wide completely, here it is completely wide like this, then there isn't any 2 point that to be displayed in the monitor. Okay, so what is the importance of this one? The importance of this one is, so in the machine itself you will find a focus. It will be like this. Mostly you will find like this arrowhead which points to the focus of this particular beam. So if you will put an organ at that focal zone, the lateral resolution will be higher. Okay, many machines has two focal zones. It will like here and it will like here. We'll see some images, don't worry. So when there will be two focus, if you will put, suppose a kidney you are doing, if you will put the kidney in this, between these two focal zones, focus, the resolution will better, the lateral resolution will better. Okay, so the resolution is usually better around the focus known as focal zone. Okay, so if you will put any organ in this focal zone, the lateral resolution will be better. Okay, now you understood the axial and the lateral. It is inversely proportional to the beam width. I told you The narrower the width, better is the resolution, lateral resolution. It is inversely proportional to depth, because while the moving, the beams get wider first. Second, the beam get less intensity, the intensity of beam lessens. Okay, it gets weaker. Next, gain. It is directly proportional to gain. We will discuss regarding the gain. Gain simply means when the beam will be weaker, you know that the beam, the echoes, or you can say beam will be weaker and the echoes will also be weaker. So if there will be any method, by any method, you can increase the intensity. Intensity simply means amplitude. Okay, amplitude of the wave. If at all there will be any procedure by which the intensity can be increased, then it is known as gain. Okay, you are giving something, the machine is giving something, so that this weaker signal can have slightly higher amplitude and it can be better interpreted in the screen. Okay, so that is known as gain. Okay, gain simply means increasing the amplitude of weaker things, weaker pulses. Okay, so it is directly proportional to the gain. You see here the image. Here is the kidney. Okay, if you see, look, this is the kidney. See the focal points. Here is one focal point, here is another focal point. In the screen, in your machine, it varies from machine to machine, you will find some arrows. These arrows are nothing but the focal points. Okay, so the focal zone will be like here, like this. So if you will put any organ between these structures, the lateral resolution will be much better, the image quality will be much better. Okay, so the next thing is the attenuation. I told you about attenuation. It simply means reduction in the intensity, reduction in the intensity of sound wave. Intensity is basically represented by amplitude. So attenuation can happen in three ways: absorption, reflection and scattering. I have discussed regarding the reflection. Okay, here you see an image. You can see the thickness of the wave. You can see gradually when it will be hitting different interfaces, some part will be lost through reflection, so it will get slightly thinner, then some reflection, it will be much thinner, then some reflection, much thinner. Okay, in this way it loses some intensity through reflection. Also there will be some through absorption. Absorption simply means while passing through the organ itself will absorb some sound waves, and it is mostly lost in the form of heat. Okay, you can say the absorption is lost in the form of heat. Some things will be lost by the organ itself or tissue itself, and there will be scattering. See, suppose this is a liver lobe. So while moving, suppose this pulse is moving like this and it has hit the interface. Okay, suppose here is fat and this is liver. So while the hitting the fat and liver interface, it will reflect something. Okay, and the liver will absorb something, but inside the liver there will be different type of tissues. As a whole, liver is an organ and as a whole it is a tissue, but there is inside that tissue there is different type of tissue. Okay, different type of structures like this. Okay, different type of structure, those are microstructures. So when the pulse will hit those microstructures, there will be small amount of, you can say that, reflection, small amount of reflection. It may not be all going to the transducer, but it may go in different directions. This is known as scattering. In radiology also you have known about the scattering. Okay, when it will hit in some different angles to the bone, it may scatter. Okay, so those scattering can hinder the final image. So here also scattering hinders some final image, and the artifact caused by scattering is known as speckle, or also called as noise, ultrasound noise. Okay, there are modern ultrasound machines which used different frequencies to reduce this speckle or noise. Mostly the spatial compounding will discuss. Okay, those techniques or the tools are used to reduce this particular scattering, but through scattering some form of energy or intensity will be lost. Okay, and with gradual going down, the intensity will be lesser, and the signals which or the echoes will be going to the transducer, it also will be weaker. Okay, so to compensate this, there is a setting known as gain, which will apply or give some amplitude to this echo so that it can reach the transducer and image can be formed. We'll see. Okay, don't worry. So here are two images. You can see here, this is actually the bladder. I'm sorry. So this is bladder, this one is the bladder, and here is the colon. Actually this is colon. So what happens when sound beam will be passing like this through pulses? It has hit the colon. Colon has some mineralized structure. These are some mineralized structure. What happened? All the things, mineralized simply means kind of bone. Okay, so all the waves will be reflected back. Nothing will go beyond this, and this is known as acoustic shadowing. I told you. Okay, acoustic shadowing. The intensity of sound wave is lost mostly in the form of reflection. All of them mostly a reflection, and nothing goes behind this, and there is acoustic shadowing. Here also I have already shown you this image. Okay, what will happen as these interfaces, it will hit most of the sound waves. Some will be lost through, some will be while passing through this is muscle, while passing through the muscle, some will be lost through absorption or heat production, and when it will hit these interfaces, most of them will be reflected back. There is further reduction of this the sound wave through reflection, and some will be scattered because it may hit some different angles. Okay, some will be through scattering. So by this, the intensity of the sound wave is lost at this interface. There is nothing beyond this one, and there is black. Okay, so these three are the primary methods through which the beams get attenuated. It simply means it gets weaker. Okay, absorption, reflection, and scattering. Remember, regarding the scattering, there is an artifact known as speckle or noise. Okay. Next is the refraction. No new thing. You have seen some in optics. You have read that when there is in the interface two different interface, the acoustic impedance is Z1, here is Z2. Suppose different acoustic impedance, velocity is same, we have assumed, it simply means different tissue density, and a sound wave hits at this interface. Instead of going like this in straight in parts, due to the change in velocity, it is slightly deviated towards, or it can go much further depending on the different densities. So this is known as refraction. Due to refraction, there is an artifact known as edge shadowing. We'll discuss, don't worry, when we will discuss the artifacts. There is an artifact known as edge shadow or edge shadowing. Next, the instruments. What are the instruments that are used in ultrasonography? First is the pulsar or transmitter. You see, inside the transducer only the transmitter will be there, but I am discussing separately. So what it does, it applies precisely timed high voltage pulses into the tissues. One pulse is usually 2 to 3 wavelength. I have already discussed. The important one is the pulse repetition frequency. What is pulse repetition frequency? You see, this is the transducer and this is the field. What will happen? A single pulse will be going like this, and there will be reflection at different points. So all those reflections or all those echoes will be taken up by this transducer, or will be received by this transducer and analyzed before another pulse generates. Okay, because if before all the echoes has returned to the transducer, if another pulse comes, it will interfere with the echoes. So first one pulse will go to the deepest point and all the echoes will be analyzed. Then after next pulse will be given off. So the time difference is basically pulse repetition frequency. Okay, but in practical, the pulse diagnostic period is 0.001 to 0.0001 second. Okay, you can see 1,000th of time one pulse is sent. So in 1 second 1,000 pulse. Okay, it is very fast. So in naked eye you cannot see. Okay, but the pulse repetition frequency 0.001 to 0.0001 second. Okay, this is pulse repetition frequency. Next, the transducer, the most important thing, whatever you can say, Okay, so transducer or probe, or sometimes called array. So it has a dual role, transmitter as well as the receiver. In older probes, they come with single frequency, but in modern transducers, the frequency has multi-frequency operation. Usually, you will find 3 to 7 hertz or 5 to 12 megahertz. Okay, the range will be there. You can select any type of frequency. But the advanced transducers, it has the ability. I told you. Suppose this is the transducer. So the near field will have a brighter image, and the far field will be darker image. Suppose I am using only 4 hertz. Suppose 4 hertz. Okay, so the 4 hertz is kind of low frequency thing. So what will happen? This near field will get a brighter, and suppose, let me take another example. Suppose I will take 12 hertz. 12 is kind of higher range. So when you will be using 12 hertz, the near field will have a better resolution, but it will not penetrate to the sufficient enough to the far field. So the far field will be lower resolution. Suppose there is some kind of technology, if I will evaluate this near field with 12 hertz but the far field with 4 hertz, then I can have a better resolution of this far field, because 4 hertz will penetrate to the deeper tissues because it has higher wavelength, and also the attenuation is comparatively less to the 12 hertz. So these kind of ability is in advanced transducers. This kind of ability is there. Simultaneous imaging of near and far fields with sound waves of different frequencies. It can use both higher frequency range and lower frequency range for evaluating the far field and the near field structures. Okay. So these are different types of transducers. Mostly you will find linear array or linear transducer. This is linear array. You can find the curved transducers. It can be large curvilinear and it can be microconvex, and the last one is the phased array or phased transducer. We will discuss one by one. First one is the linear transducer or linear probe or linear array probe, it is known as. So it has a rectangular field of view. You can see here it has a rectangular field of view. It offers highest available frequency. Linear probe it can go up to 18 megahertz, okay, but not the curvilinear. Largest near field image, because you see it has a larger footprint. You can see also it has a larger, I have not written, so I think it has a larger footprint. You can see here it has very big footprint. Due to the bigger nature of the footprint, the near field will have a better image. Suppose here if you will draw a microconvex, it will look like this. It will look like this. So you see, suppose the up to this is the near field. This is near field. You can see that when we will be using microconvex, only this much is evaluated. But in case of linear probe, you can see it has a better evaluation of the near field structure as well as the resolution of the near field structure. And it has a large skin contact. I told you footprint. It has a large footprint compared to the curvilinears. It has limited far field width view, because you see in case of microconvex the width is kind of high, especially the far field, but due to the rectangular nature in linear probe, it has very narrow far field view. Okay, but in case of modern linear probe has trapezoid view like this one. This one is a modern linear probe. It has a kind of trapezoid view, still less than the convex ones, but still the far structures has a comparatively wider view. This is linear probe. Next is the curvilinear. It has kind of two types. One is large curvilinear, another one is the microconvex. This is the large curvilinear probe, this is the microconvex probe. Large curvilinear probe has a bigger footprint. You can see here it is a bigger footprint compared to the microconvex, which has comparatively less or small size footprint. Large curvilinear comes with 1 to 8 megahertz and the microconvex 5 to 12 megahertz. In the linear it can go up to 18 megahertz. Okay. So microconvex is the most versatile one. If anyone asks which probe is the most versatile one, is the microconvex. Microconvex probe is the most versatile one. The advantage is the wider field of view, especially the far field view. Far field view, if it is near field view, it is far field view. The far field view has a wider comparative to the linear probes. It is much wider, but it has a limited. This is a disadvantage. Okay, advantage of the linear is the disadvantage of this curvilinear. So near field view will have some degree of compromise. Okay. So this is basically curvilinear. Next is the phased array probe, or phased probe. It is also known as cardiac probe. So what here it does, the piezoelectric crystals will be like a block like this. So the footprint is very small, very small. The advantage of this one is between the ribs you can place this probe, as it has very small footprint. So between the ribs it can send signal, okay, or send sound waves, and the heart can be evaluated. Okay, unlike the curvilinear and also the linear, which has a very big footprint, it cannot be placed between the ribs for the evaluation of the heart. So for the heart, this probe is the best, the phased array, where simply a small block is kept so that the footprint will be very small, and through the ribs it can be kept and the heart can be evaluated. Okay, very small footprint, designed for the cardiac applications. It can also be used, or most commonly, or you can say better used, for CW, continuous wave Doppler. Okay, it is a method through which heart is evaluated. If you will go for echocardiography in further classes, we will discuss. Availability 2 to 3 megahertz, 5 to 7 megahertz, 10 megahertz, or even some higher range probes are also available. So these three are most basic ones. Apart from that, you will also find 3D probes. Nowadays 3D ultrasound is I think there are some colleges which I am known for going for different conferences. I have known that. So 3D probes are also being used for 3D ultrasonography. This is a 3D probe. This one is a 3D probe. You can see it is kind of ball like structure. So here this is a fetus actually, which is evaluated. It is a kind of better image, 3D image. Okay, so for that special probe, 3D probe. It can be curvilinear, it can be linear. This is 3D probe. Next structure is the screen, in which you view all those things. So the screen varies from machine to machine. Although probe is kind of constant, but the screen can vary, information can vary. Okay, so if you have some machine, please know that what are displayed, but there are some basic things which are displayed, like transducer type. Here you can see that general LA, it is written here general LA, simply means linear array probe. Transducer frequency, here you can see it is written 4 to 13, 4 megahertz to 13 megahertz, and here is the indicator. Here it is slightly towards the 13 side, or you can higher frequency is being used for evaluation of this particular organ. Mode, you can see here B res is written, B mode resolution, that is being used. Transducer indicator, here you can say bar, sometimes here it may be a point, sometimes it may be like C, or they varies from machine to machine. Okay, company to company it varies, but you will find an indicator which match with the marker in the probe. When we will be discussing the nomenclature of the images, we will discuss. Dynamic range, okay, here you can see PRC, P for dynamic range, R for the enhancement, C for the line density. There are some values. Okay, next focal point I have discussed regarding this. These are the focal points. Electronic course distance, you can see here one plus sign. Okay, these two are electronic courses. The distance between them here is the D1. Okay, the distance between these 2 points. So the from the cranial port to the caudal port, the distance is 3.45 centimeter. Okay, this is electronic cursors. Depth indicator line, you can see in the right hand side. Here you can see depth 0, 0.5, 1 centimeter, 1.5, 2 centimeter, like this, 0.5 centimeter or 5 mm increment like this. Organ of focus, here in the image, this is the organ of focus. So machine to machine it varies, but first you should know that all those things, and depending on which machine you have in your college or in your clinic, you can see that how it is being represented. Next is the control panel, or you can say the scanner control. Here also it varies from machine to machine, but there are some things like this keyboard for entering the data. This is the TGC. Okay, TGC, we will discuss regarding the TGC, time gain control or time depth control, all the name. So this is TGC. Here you can say it is B mode or M mode. Okay, all those things. This is zoom. So it varies from machine to machine depending on which machine you have. Please get acquainted with the things. But there are some controls which are basically very universal to all the machines, like a power controller. The power control basically decides the strength of or the intensity of sound wave that is going to the body. It controls the pulsar. It is the only control which controls the pulsar. Other thing controls the image, that is the echoes. After echoes, image will be formed. So all other settings will control the image formation, that is the controlling the echoes. But this is the only control which controls the pulse that is going into the body. Okay, it can increase the strength or intensity of a pulse, okay, by simply increasing or decreasing the power control setting. But in practical point of view, even the book suggests that it should be set at the lower lower setting possible. You should manipulate other controls, that is the image controls, rather than manipulating this one, because when it is set in higher frequency higher setting, what will happen, the louder noise will go into the body. It may interference with the other organs or other problem may arise. That is why it is not recommended. You should go for higher setting power control. It should be kept lower setting. This is the example of two images. This is lower, this is higher. You can see, just see how difference is there. Here the brightness is kind of dull, here the brightness is kind of more, and the things like here there are two cysts here, but it is not visible. But when the power setting is to higher side, you can see the far field structure. These two cysts are visible. Okay, so this is power control. It is the only control which controls the pulse. Next is the very important one, is the time gain or depth gain compensation control. So what is it? Is the main focus of this one. Main focus is that, you know, that I told you, when the pulse travels through the tissues, the near field structures has a stronger echo and the far field structures has a weaker echo. Due to the weaker echoes, you will find some dark areas. Okay, so those areas will have more darker appearance, and you may not be evaluating those structures properly. So to avoid those, so what will happen, there are some settings through which those weaker echoes, the amplitude will be increased. When the amplitude of those weaker echoes will be increased, it will travel all along the tissues and will reach the receiver, and the image can be formed. So it is used to produce an image that is balanced in brightness. I told you the near will be more bright and it will be more dark. So if there is some control through which there will be uniform brightness, then the entire field can be evaluated nicely. So the function is simply to have a balance in brightness from near field to far field, all of these things. It is used to reduce the near field brightness. I told you near is more bright, the far is comparatively darker. So this particular thing is used, TGC, time gain control, is used. So this brightness can be slightly lessened and this brightness can slightly enhanced, the far field one. Okay, so brightness and increases the brightness of the far field brightness. Okay, so this is basically TGC. You will find a symbol like this in your machine which represent TGs. So first, this portion is the near gain, this is the slope rate, and this is the far gain. Okay, represents the far gain. You don't need to go very technically into that one. You will see some images, don't worry. See these images. You see this is an art. Okay, so the settings is basically an art, varies from species to species, organ to organ, all those things. So here, see here. These are 4 images in 4 different settings of TGC, time gain control. Here each alternate knobs are set on lower and higher side. You see how images are found. This is more, this is bright, dark, bright, dark, bright, dark, like this, because the settings are like this. Here each alternate 2 knobs are up and down. You can see slightly thicker, bright, thicker, then dark, bright and dark. Here some in diagonal, but here you see the far field is highly bright and the near field is highly bright and the far field is kind of dark. Still it is not uniform. Okay, it is not correct way to evaluate. Now when the properly the TGC is controlled, you can see that uniform brightness as well as the structures are comparatively more kindly vividly visible. Like here these structures are not that visible, in this particular structure here these two structures are not that visible. Okay, and due to dark nature these structures are also not visible. Here you can see that the far field structures are not that good, the visibility comparatively not good, but here you can see all those things are clearly visible. This is basically the importance of time gain control TGC for managing the overall brightness of a slice or of a slice. Okay, here the linear probe is used. If you are using curvilinear, same principle is applied. Okay, so this is basically time gain control. Next is the overall gain or amplification control. It simply increases or amplifies all the echoes irrespective whether the far field or near field. There you can control at each level. Okay, as each centimeter, or you can say in few centimeters, you can control the amplitude of different echoes. But here it will, irrespective of origin point of echo, whether far field or near field, it will increase everything. Okay, so it should be used after TGC is used. You have done TGC and you have done the uniform brightness, then after this is used overall gain. Here it is without the use of overall gain, this is use of overall gain, and when overall gain is too much applied like this becomes non-diagnostic. This is non-diagnostic. This is also non-diagnostic because not structures are not that visible, but here it is kind of diagnostic. Some structures are visible. So this is basically the importance of overall gain, but in book also it is referred that it should be applied after TGC. When you have done the time gain control, then you can use the overall gain control. Okay, so remember, time gain control, you have control over each layer of echoes. Okay, different layer echoes you have control, but in overall where from it may originate from far field, it may originate from the near field, it will increase amplitude of all echoes. Okay, next is the dynamic range, or it is also known as contrast or log compensation. So it is usually expressed as decibel. It controls the contrast of ultrasound image. It can be narrow dynamic, it can be wide dynamic, also there is a mid dynamic. So narrow dynamic range will provide better contrast. Contrast simply means more black and white, mostly used in the echocardiography. Why? Because it is single organ. If you are using for the abdominal scan, you have to use wider dynamic range because it produces higher latitude image. It simply means there will be more sets because there are different organs, multiple organs. If you will be using simply black and white, some organs might be missed. So you need more shades of gray, more variety to see different organs. Okay, so you need higher latitude image, while in case of heart you need higher contrast image. There you need use narrow dynamic range. Here you have to use in abdominal scan, you have to use higher dynamic range. Narrow dynamic range basically 15 to 13 decibel, and for higher dynamic 60 to 100 decibels. There are two images. This is narrow. You can see more white and black, but here there are different sets. Okay, this is wide dynamic range. You have to select based on the scan you are using. Okay, so these are some controls. Next, the modes. What are the different modes? These controls are very basics. Okay, like I told you, power control, TGC, overall gain, and dynamic compression. These are very common, you will find in most of the machines. Okay, apart from that, there might be some different whole bunch of controls. Okay, you have to look to your manufacturer of the ultrasound machine or the company which is supplying the ultrasound machine for further controls. Okay, now coming to the modes, there are different modes of ultrasonography. Commonly A mode, or it is also known as amplitude mode. This is B mode or brightness mode. Next is M mode, that is the motion mode. First on the amplitude mode, this is a very old one, kind of outdated, you can say, outdated nowadays, not that much used. Here what actually happens, here actually A mode is amplitude mode, so it will record the amplitude. One pulse is here, it is the probe, this is the probe, and one pulse is traveling. As soon as it will hit different interfaces, there will be a spike. It has hit the cornea, one spike. It has hit anterior border of the lens, one spike. It has posterior border, one spike. Now it has hit the sclera. There are two spikes, different layers. Sclera, the choroid, outer edge choroid, sclera. So all those things, when it will hit, it will give some different spikes. So these spikes will be recorded like this. Here it will be like graph like this one. Okay. So here will be time or distance. Here will be the amplitude. This is a very old one, not nowadays, not A mode is not used. So what is the advantage? It mostly used for ophthalmic examinations. What will happen, you can, if you will measure these distance, you can see that what is the distance between cornea and lens. Suppose the lens is subluxated and it is gone to aqueous humor, so this spike will not be there. So from that you can know that this lens is subluxated. So all those things can be utilized, but nowadays it can be done with the B mode ultrasonography. There are different other modes also that can be used, okay, for the diagnosis of these structures. Nowadays this is not used. Now regarding the B mode, I have explained how image is formed. Simply the A mode, when it is put through dots, like this is a bigger spike, it will be more bright. If it is smaller spike, it will be less bright. Like this, when there will be shades of gray, then that is B mode. All those images which you have seen now, currently which we are seeing, is basically the B mode. Okay, there will be scan line, it will scan particular area and it will represent dots, then it will do the sweep, one frame, then all the images will be formed, then continuous frame, there will be continuous image in the monitor or the screen. This is B mode. Next is the M mode. M mode is motion mode, mostly used for echocardiography. Because heart is continuously moving. For the evaluation of the heart, it is used M mode. So here what you have to do, this is the scan area, this is completely scan area. Suppose you have to evaluate the walls of the heart, so you will select a scan line. This is the scan line. In the scan line, try to bring all the walls. Here you can see, okay, this is the right ventricular wall, this is the ventricle, this is the intraventricular septum, this is the ventricle, left ventricle, this is left ventricular wall. Here you can see RVW, right ventricular wall, this corresponds to that, right ventricle, interventricular septum, left ventricular wall. So when it will move, you know it is continuously moving because the chamber is continuously moving, so it will produce a graph, okay, produce an image. You can see here left ventricle, one contraction, relaxation, contraction, relaxation, contraction, relaxation. So all those things will be recorded in form of a moving, or you can say video or a static image, which can give the data regarding the different phases. Okay, when we will discuss, if we are going to discuss echocardiography subsequently, we will discuss. So basically the M mode is motion mode, so it is mostly used for echocardiography. Okay, so here different moving structures are evaluated, especially heart. For heart, the M mode or motion mode is used. These are basic three modes. A mode, amplitude mode, completely outdated. B mode, most commonly used, B mode. Then the M mode. These are the things which are very common. Okay, mostly the B mode and M mode. M mode is for echocardiography, B mode, rest other structures is B mode. Okay, whatever the images you are seeing, B mode only. So these are the three modes which are basically used for ultrasonography. Now there are some new imaging modes also, like tissue harmonic imaging. So what will happen? Suppose here is a probe. This is 4 megahertz probe. So in the tissue harmonic imaging, usually when 4 megahertz will be sending pulses, like here it will be sending some pulses, so it will listen to 4 megahertz echoes. So what will be echoes coming? It will listen to 4 megahertz. But in case of harmonic frequency echoes, so this 4 megahertz, which is the probe, is the fundamental frequency. It is known as fundamental frequency. Fundamental frequency. What is harmonic frequency? The multiples of the fundamental frequency is known as the harmonic frequency. Suppose if the fundamental frequency is 4 megahertz, the harmonic frequencies will be 2f, 3f, 4f. Like this it will go. 2f means 8 megahertz. Okay, so 3f will be 12 megahertz, 4f will be 16 megahertz. So instead of listening to the fundamental frequency, the machine will listen to the harmonic frequency, 8 megahertz, 12 megahertz, like that it will listen. It improves the image quality. Like here you see, this is the examination of the bladder. Okay, you can see how bladder looks, and this is with harmonic imaging. You can clearly see that it is comparatively better. Here are some artifacts, like this is the acoustic enhancement. So when the sound wave moves from this is fluid, here will be fluid. This is low acoustic impedance to high, it will be enhanced. Okay, more reflection will be there, it will be enhanced. So low to high, when it will move, there will be acoustic enhancement. So here there is also side lobe effect. All those things we will discuss when we will discuss artifact, but simply look. Okay, here is a radiograph without tissue harmonic imaging. Here is a radiograph with tissue harmonic imaging. You can see that it is comparatively better. Walls are better described, or better detail is there, and there is a less artifacts like acoustic enhancement or acoustic side. All those things are less. So this is basically tissue harmonic imaging. The machine will do that. You don't need to worry, don't need to remember anything. Okay, everything you should not remember. Simply know that there is some things available with that one, and you can use that. So this is tissue harmonic imaging. Another one is the spatial compounding. Spatial compounding, I told you that it is used to reduce speckle. It is used to reduce speckle. Okay, so here the fundamental thing is multiple scan line is used instead of using single scan line. This is single scan line. So when the single scan line moves like this, okay, so beam sweeps like this, there will be scatter. Okay, but if you use multiple beam lines, here actually in the transducer itself a needle is pierced so that to show different scan lines. This is single scan line, this is multiple scan line. But advantage of multiple scan lines, the scatter produced by this scan line will be attenuated by this one, or counteracted by this one. So there will be less speckle. So multiple scan lines, you can see here 3 scan lines. Okay, so this is basically spatial compounding. It is a mode available with the ultrasound machine if you have that in your machine. Another one is extended field view. Simply means there will be panorama picture. Okay, here you can see a panorama, bladder, prostate, all those things. If you will do simply sector, then this will be like this. But with this particular view, you can simply adjust your probe and take a panorama picture. This is basically panorama view. Another one is the 3D and 4D ultrasound. It is available with very few ultrasound machines. If you have, then you can take a advantage of this one. 3D, I told you, 3-dimensional. This is a fetus. This is a 3D view. 4D view simply means 3D view in motion, or real-time 3D is known as 4D. Apart from that, there are many other features like contrast enhanced ultrasonography, contrast enhanced. There is also elastography. I have done research on elastography. Actually, this is my subject kind of, but it is kind of advanced ultrasonography, not in standard ones. So all those things can be available with your ultrasound machine. You can check that. So all these are different additional things like tissue harmonic imaging, spatial compounding, panorama view, and these 3D and 4D view, elastography, contrast enhanced ultrasonography. These are additional features. The normal ones are B mode, M mode. A mode is not that used. These two are normal. Apart from that, all those things are available. It can be available. Apart from all features, other features like Doppler, okay, all those things may be available with the machine. Do check that out. Okay, but this is basically some introduction to the ultrasonography. In the next class, we will go some technical terms or associated with the images. Okay, with the cranial caudal, what are the markers, and what is echogenicity, anechoic, aechoic, all those things will be covered in the next class. Okay, hypoechoic, how they are diagnosed, all those things will be discussed in the next class. So if you like this video, please do share among your friends, juniors and seniors. Okay, we'll meet in the next class. Till then, tata, bye bye, take care.